About the anti-glaucoma drugs. Before learning this anti-glaucoma drugs, we should know a basic knowledge about the what is glaucoma and what is the pathology which leads to glaucoma and what is the treatment strategy. Let's see the mechanism of glaucoma. The glaucoma is the increased intraocular pressure more than 40 mmHg. The intraocular pressure more than 40 mmHg with some retinal changes are called the glaucoma. This glaucoma may be an open angle glaucoma or the closed angle glaucoma. Before learning the glaucoma, the normal intraocular pressure it's due to this aqueous humor. The aqueous humor which is present in the anterior chamber and posterior chamber is responsible for this intraocular pressure. Let's see the synthesis, production and absorption of this aqueous humor. The aqueous humor which is produced from the ciliary body, it enters the posterior chamber and along the iris it takes a turn and enters into the anterior chamber. Through this anterior chamber it circulates and gets reabsorbed at the level of trabecular meshwork. This is the site of synthesis, circulation and absorption of this aqueous humor. The aqueous humor is essential for providing the nutrients to the avascular structures, that is cornea and lens. As the cornea and lens are the avascular structure, this aqueous humor only transmits the nutrients and removes the inflammatory cells. So when there is the pathology in this glaucoma is when there is increased production of this aqueous humor or there is any blockage, so that aqueous humor is not absorbed, leads to the increased aqueous humor within this anterior and the posterior chamber, and which in turn leads to the increased intraocular pressure and which in turn leads to the retinal changes, and this leads to the phenomena called as glaucoma. So the treatment is targeted at either decreasing this production site. Remember this pathology as the tank which is filled with the tap which represents the production site, and it is regulated by the two outflow tract, that is trabecular outflow and evioscleral outflow. The main is the trabecular outflow. Here the treatment targets are either we are planning to reduce this production site, or we are planning to increase this trabecular outflow site, or we are planning to increase this evioscleral outflow, so that a minimal amount of water which is present in this beaker, which is represented as in the anterior and the posterior chamber, and decreased effect of glaucoma. Let's see each of this. When we are planning to decrease this production site, we have three groups of drugs. This can be remembered as A, B and C. Here A stands for adrenergic agonist and B stands for beta blocker and C stands for calcium channel blocker. Let's see each of this. When we are targeting at the alpha receptor with the help of adrenergic receptors, it causes decreased aqueous production. Thus the target is achieved, the production is decreased and trabecular outflow is increased, plus evioscleral outflow is also increased. So we have to stimulate this alpha receptor. In case of the beta receptor, when it's stimulated, it decreases the trabecular outflow. So we are planning to block this receptor. So with the help of beta blocker, we are plan to increase this trabecular outflow. In concern with the production, we have to decrease this production, we have three groups of drugs. We have A, B and C. A stands for alpha agonist and B stands for beta blocker and C stands for carbonic anhydrase inhibitors. And in case of increasing the trabecular outflow, the main outflow of the aqueous humor, we have the again alpha agonist which is included in the trabecular outflow, and myotics, which means the parasympathetic stimulation, which leads to decrease in the size of pupil and helps in the increasing outflow of trabecular, which relieves the glaucoma. It also included in the increased trabecular outflow. And rho kinase inhibitor, which is a new drug which is included in this increased trabecular outflow pathway. That new drug is called the netrasudil, which is a rho kinase inhibitor which increases the trabecular outflow, so that all the excess aqueous humor is excreted through this trabecular outflow and reduces the intraocular pressure. That is netrasudil. And the side effect concerned with this netrasudil is it causes vortex keratopathy and cornea variculata. The cornea gets keratopathy, that is called the vortex keratopathy. That is the main side effect concerned with this new drug, that is rho kinase inhibitor or the netrasudil. In case of increasing the evioscleral outflow, which is a minor outflow tract, we have prostaglandin analogs. Mainly, we have prostaglandins. PGF2 analog is involved in this evioscleral outflow. Apart from this drugs, we have hyperosmotic agents, that is mannitol, urea and glycerol. These drugs are given in the acute conditions either as an IV, so that these are the highly osmotic substance, so it absorbs all the extra water from the body, which also includes this aqueous humor, thereby reducing the intraocular pressure. So these substances are also used in the treatment of glaucoma, which includes mannitol, urea and glycerol. Next, moving on to the alpha agonist. When the alpha receptor gets stimulated, it have all the preferable actions for the treatment of glaucoma, that is it decreases the aqueous production and it increases the trabecular outflow and also increases the evioscleral outflow. This alpha agonist may be the epinephrine or depinephrine, which acts like an epinephrine hormone, and these are at the level like in neurotransmitters like epinephrine and depinephrine. And at the level of receptors, we have clonidine, apraclonidine and brimonidine. Here, these are the alpha 1 or 2 receptor agonists, which helps in the treatment of glaucoma. The side effects concerned with the alpha agonists are the brimonidine, which crosses B4 blood-brain barrier. It causes the blood-brain barrier and it causes drowsiness in the patients. So, brimonidine causes drowsiness or the apnea, so it is contraindicated in the children less than 2 years of age. Whereas concerned with the apraclonidine, which has more of alpha 1 agonistic action than alpha 2, which leads to this lid retraction and mydriasis, which is seen with the apraclonidine. And clonidine, which is an preferably alpha 2 agonist. This alpha 2 receptor is a autoinhibitory receptor because of this is a G protein coupled GI receptor. When alpha 2 gets stimulated, it auto inhibits itself. So alpha 2 is the receptor agonist or clonidine, apraclonidine and brimonidine. And these are the side effects concerned with this alpha agonist. And moving on to the beta blockers. The beta blockers ends with the letter OL. These are the beta blockers and this helps in decreasing the aqueous production. But they have some side effects. When we use the non-selective beta blockers, for example timolol, it causes systemic side effects and it also blocks. Here this can be remembered as beta blocker, so it blocks the corneal sensation. These are the side effects concerned with the beta blockers, and it also causes punctal stenosis, which is seen with the beta blocker. So because of this systemic side effects, they are contraindicated in patients with asthma, COPD and congestive heart failure, AV block and bradycardia. So these are the contraindications of use of beta blockers in case of glaucoma. When the beta blocker is in asthma patient is given, it causes further bronchoconstriction, so they are contraindicated on asthma patients. And in case of heart failure or AV block and bradycardia, the beta blockers decreases the heart rate and it also decreases the cardiac output, so they are contraindicated in case of congestive heart failure, AV block and bradycardia. We also have the selective beta 1 blockers, that is beta hexol, with the minimal systemic side effects are also preferred. Moving on to the carbonic anhydrase inhibitors. The carbonic anhydrase inhibitors decreases the production of aqueous humor by decreasing the fluid transport. And we have 3 groups of drugs, that is acetazolamide. In case of carbonic anhydrase inhibitor, they end with amide. So we have acetazolamide, torzolamide and brinzolamide. Here acetazolamide is an oral or an IV drug, but it is contraindicated in case of sickle cell anemia. Whereas the torzolamide or the brinzolamide are used as in topical eye drops. But we have the side effect like it causes corneal edema and systemic side effects. All these first group of drugs, that is in decreasing the aqueous production group of drugs, beta blocker, carbonic anhydrase and alpha agonist, cause systemic side effects. Next, moving on to this increasing the drugs which increase the evioscleral output, that is prostaglandin analog, and most particularly that is PGF2 analog. In the PGF2 analog, the drugs end with the letters prost. We have bimatoprost, latanoprost, travoprost and tafloprost. This prostaglandin analogs is an active form which enters the ciliary receptor muscle and converted into metalloprotease. This metalloprotease in turn increase the evioscleral outflow. This is a mechanism which helps in the glaucoma treatment. But we have some side effects concerned with this prostaglandin analogs, and this can be remembered with a mnemonic as PROST. that is latanoprost and bimatoprost. Here P stands for periorbital fat get decreased. Periorbital, P stands for periorbital fat, and R stand for iris pigmentation. And the patient will be having different colored iris, that is called the heterochromia iris. And O stands for the edema. The edema is the macular edema. And T stands for trichiasis. Trichiasis means increased number of hairs in the eyelashes is called the trichiasis. So the side effects concerned with this prostaglandin analogs are decreased periorbital fat, iris pigmentation, and edema or trichiasis, which is hypertrichiasis of eyelash. This also can be remembered that our eye looks prettier when it is a colored and with a more eyelashes. That is the side effect seen with this prostaglandin analog. And we have another group of drug, that is the myotics are the drugs which decreases the pupil size, whereas which helps in the increased trabecular outflow. These drugs are cholinergic agonist and anticholinesterase, because the parasympathetic stimulation only causes the myotics or decrease in the size of pupil. The cholinergic agonists are pilocarpine, whereas the anticholinesterase are inhibits the cholinesterase, whereas which helps in the increased level of acetylcholine and which produces this parasympathetic effect. These drugs are ecothiopate. These drugs are used in the treatment of glaucoma, thereby decreasing the trabecular outflow. But we have some side effects concerned with this myotics are it causes retinal detachment, and once the patient started with the myotics, present with floaters or flashes or blackish background due to this retinal detachment, and some may present with the cataract. These are the complications seen with the myotics. These are the treatments for glaucoma, and in case of the open angle or the closed angle glaucoma, the first line is, in case of open angle glaucoma, is the prostaglandin analogs, that is prostaglandin PGF2 analog, that is prost, the drugs which ends with the prost, latanoprost or bimatoprost. And in case of angle closure glaucoma, the angle is get blocked, which means this is a closed angle, so the trabecular outflow is blocked, and the drug which helps in this acute angle closure glaucoma is IV mannitol or acetazolamide, which can be given as an oral drug, or a beta blockers and aproclonidine are the drugs which used in the acute angle closure glaucoma.